If you're active or take care of people who are active, then you've probably heard of the term plantar fasciitis. Now, that term might be a little outdated, and I'll explain more about that in a bit, but it proves the point that this is a very common problem. Today, we're going to talk all about it, so let's dive into it. Welcome back, everybody, to the Building Lifelong Athletes podcast. I'm your host, Jordan Rennicke. Thanks so much for stopping by. I really appreciate it. If we've never met before, I'm Jordan. I'm a dual board certified physician in family and sports medicine, and the goal of this podcast is to keep you active and healthy for life through actionable, evidence-informed education. And today we're talking all about plantar fasciopathy. We're talking about what the plantar fascia is, how this condition presents, how to diagnose it, and how we think about its treatment. So let's get started. All right, let's start off with some prevalence and incidence. So the lifetime incidence is about 10%. That means 1 out of every 10 people are going to experience this at some point in their life. That's a lot of people. And about per year, it's about 2 million. And of these cases, about 1/3 of them are bilateral, so both sides. And so that's a lot. And this is a common condition we see in runners. There's a lot of runners who get this. They say anywhere from 3 to 7% of runners, but very common condition we see in runners. And so we care about this because we see it all the time, whether it's in primary care clinic or just talking with your friends, whatnot. Like, this is a very common condition. Plantar fasciitis, people will say. We'll talk about that in a second, but very common. Let's move on then to some anatomy. And here, essentially, this is a ligament. Technically is going bone to bone, but it's technically fascia, which is a connective tissue that kind of surrounds multiple things in the body, like our organs, muscles, nerves, and also here can provide some support and structure as well. It's a very thick structure. And it originates from the calcaneus, the heel bone, and then goes to the proximal phalange or the toes. And there's 3 main bands. And if you look here, and if you're on the video version right here, that works perfect. But if you're just listening to it, I'll try to explain it. Here is the bottom side of the foot, the plantar aspect of the foot, and there's 3 big bands. This is really big and thick, as you can see. And right here, we have starting in the calcaneus is where it starts, and it kind of goes through. We have the central band, right? So this central one is the one we really think about. This is the most common one, the most commonly affected with pathology, what we see, but that's the big one. But we also have a medial band here, and then we also have a lateral band here as well. So we have 3 different bands of the plantar fascia. Most likely it's going to be this central one that's giving you problems, but that's it. And that's specifically the big thing is from an anatomy perspective. That's going to give it away, right? Where I have that pain, and we'll talk more about how it presents. But from an anatomy perspective, this is a really big structure, right? It covers an enormous part of the plantar aspect of the foot, and it helps provide structure and support, and helps create and maintain that arch of the foot. So that's what's really important. Is it's not just sitting there. It's not just like it's a thing there. No, it helps provide structural support and maintain that arch. And so it is really important. And every time you're walking, you're using it and putting stress on it. And so from an anatomy perspective, you think about these big bands. It's very thick, and that's what it's generally think about what it's doing. It's providing some support in those situations. So moving on from anatomy, then next we'll go on to our pathophysiology. And the question is, what's actually causing this? We used to think it was inflammatory. That was the big thing, plantar fasciitis. We used to think that, hey, it's irritated. We've got inflammation everywhere, but updated histological studies kind of show it's more degenerative in its nature. So they're seeing degenerative changes when they take a piece of the plantar fascia and look under a microscope, more degenerative type cells and not necessarily inflammation. And this goes hand in hand with our tendinopathy lecture, right? This looks very similar to a tendon in terms of how we treat it and kind of how it changes chronically over time. And so is there a possibility that it's an itis, meaning inflammation? Yeah, at some point there's probably some inflammation to start, but most of these turn into kind of this degenerative type changes like we talked about with tendinopathy. So that's typically what we're seeing, and kind of going hand in hand there. Terminology, people who say plantar fasciitis, that is now outdated. If you're saying it, it's super common, so I'm not saying you're wrong, but you're wrong just because it's probably not actually doing that. Not in a mean way, like, hey, you can say that if you want, but it's probably not an itis, like an inflammation, because that matters, right? Because when we think about an itis, inflammation, we treat that with its own set of treatments, right? And you think about maybe reducing the inflammation, all that stuff, but a lot of times there's no inflammation to be had, then that's not what we're going after. So like most other tendon things, it's more of a degenerative type condition. And so just like for tendinopathy we talked about, we can talk about fasciopathy. So kind of this fasciopathy pathology of the fascia. That's kind of more accepted. It's indicating more of that long-term degenerative type changes. And a newer term here is called plantar heel pain. So plantar heel pain, that means, hey, there's some pain down in the foot, and it can cover a whole multitude of things. We have multiple conditions that could be happening. We'll talk about with the differential diagnosis later, but that covers like a whole multitude of things. But if you're looking at the artist formerly known as plantar fasciitis, in the general sports medicine community, are saying fasciopathy now, just because that's more indicative of what's actually going on. So just a fun fact, if you want to impress your friends, talk about plantar fasciopathy. Actually, just kidding. You'll be a nerd. They'll make fun of you. But let's move on to risk factors that we're talking about here. So risk factors, there's 2 main categories. There's the athletes and then the everyday folks who are usually sedentary. From an athlete perspective, it does seem like runners have a higher risk of getting this, and the more you run, the higher the risk, which is probably like the least shocking news of the day, right? If the more you do of anything, you're probably at a high risk for overuse injuries. And it seems like in athletes, the more you run, the higher risk you have of having this. And then for our everyday folks who are usually sedentary, the biggest risk factor is BMI. So meaning a higher BMI, you have a higher risk factor to develop plantar fasciopathy. Other things they've talked about are reduced ankle dorsiflexion, maybe work-related weight bearing, meaning, hey, you're on your feet all day. And so that does seem to maybe have a rule. It's not as slam dunk or obvious as the BMI one. So that's one thing from a modifiable risk factor thing we talk about with patients is, hey, if BMI is elevated, that does increase the risk of, patients having it and may improve. We'll talk about treatments wise, may be helpful in that perspective. But risk factors, I think about either those super active people. And once again, from a risk factor perspective, like all these things go out the window if anyone's starting something new. Like we'll talk about presentation, but they just increase their workload. And so that's something we just kind of think about there as well. And so moving on to our presentation exam, how does this present? Well, typically we have pain on the plantar aspect of the foot. And by plantar aspect of the foot, I mean on the bottom of the foot, right? On the arch. If you look at this photo here, the bottom of that is going to be our plantar aspect. We're going to have pain right underneath in this area. Typically it's worse with the first steps out of bed. That's one kind of classic one is, hey, I have this pain kind of on the bottom of my heel. When I got out of bed, it's like the worst. And then I get up and it starts feeling a little bit better. But then if I use it too much over the day, then it gets worse. That's a classic pattern for plantar fasciopathy is worse, like first step out of bed and then gets a little better, kind of warms up. It's almost like a tendinopathy, very much like a tendinopathy where it hurts when I first start, then it kind of loosens up, warms up. And then if I use too much, it gets worse again. So that's kind of how it presents. And that's like pretty like pathognomonic classic. Like if that's someone comes in, you say like across the room, like, yep, that's probably most likely going to be plantar fasciopathy. And you don't necessarily have to do a whole lot more, but that's like the classic story. And a lot of times on exam, we'll have pain with palpation at the medial calcaneal tubercle. And so if you think about that, looking at this picture here, this is showing what we have the windlass mechanism, but that's the next test. The first test though, down here in the medial calcaneal tubercle, right down here in this plantar aspect, it's where the plantar fascia inserts. And so if you call back to that image I showed just a little bit ago, where that originates from, coming off the calcaneus, the plantar fascia, if you push there, they're usually tender. That's like a dead giveaway. And then they may have something called a positive windlass mechanism test. So windlass mechanism is where we're bringing that great toe into extension here. And you can also put the ankle into dorsiflexion as well to get a little more stress on it. But you can see here in the video version that when we are really cranking this up, this is putting a lot of tension on the plantar fascia here. So it's really putting that on stretch and putting load through there. And so if we have pain with that, that is an indication that we may have plantar fasciopathy. That is not a guarantee one, meaning like, hey, it's positive, so it has to be it. But if it's positive, I feel better that it's probably plantar fascia related, where if it's negative, I'm not saying it can't be that, if that makes sense. And so that's kind of what I think about it. If it's positive, it's like, okay, that's kind of helping. If it's negative, say, okay, that may be helpful, but it doesn't necessarily rule anything out. So when patients going to come in, a lot of times they're saying they just did something, right? That's the big thing. Like, oh, I just ramped up my activity level. I'm training for a marathon now. I was doing this and now I'm doing this, or I started jumping rope, or just something. Usually there's some history component, most likely, for people. A lot of times if they're athletes too, it's like, I just increased my training. But there's also that population of sedentary people who are like, man, I just stand for a job. Like, it's what I do all day. My feet are just killing me. And so that's, as we talked about, a potential risk factor. So it's not all the time there's an increase in things, but that may be kind of just the way you think about it. And like we talk about tendinopathies, it's all about like load and, your body's ability to adapt to that load. And so when I think about this kind of this continuum, it's this seesaw, right? We have this load and recovery, or, load and how much you're able to handle. And even if you've done the exact same amount of load, if something changed in your life, meaning, hey, more stress, anxiety, depression, you're not sleeping well, you got life stressors, something like that, that could actually decrease your capacity to tolerate that load. And so even the same load that you had now becomes too much for your body to handle. And so that works for all tendinopathy, for plantar fasciopathy, all that stuff. So it's just something to think about when someone who's like sedentary, like, how can they possibly develop this? Well, it could be kind of cumulative. And at that point right now, their body's just not adapting to that, and they're not ready for it. So that's just something to consider. That's like my general spiel on overuse injuries. And jumping into imaging here, imaging is kind of interesting. We don't need this. This is not required to make a diagnosis. Imaging can be helpful to confirm things, but not needed. If we are going to image, the imaging modality of choice is probably ultrasound. And on ultrasound, if we're looking at greater than 4 millimeters of thickness seen, so essentially what you're doing is you're going in there with the ultrasound, measuring usually right at the insertion or the origin of it on the calcaneus, looking at the plantar fascia, and you're trying to measure. And if it's greater than 4 millimeters, then you might consider that to be, elevated. It's greater than, kind of normals are hanging out a little less than 4. So if it's greater than 4, you think about maybe this is positive. As I've talked about in pretty much all my imaging lectures, if you scan someone and they have a thickened plantar fascia, but they have no pain, then they do not have plantar fasciopathy. That's not how it works. But you may see those changes in someone who has that. That kind of works like one-on-one. Okay, we have pain and thickening. We probably have some plantar fasciopathy. You also might find some hypoechoic areas, which are black areas on the ultrasound. X-ray is not necessary. You'll probably see calcaneal spurs. But in some studies, about 89% of patients who had plantar fasciopathy had this. So a plantar spur right on the bottom, we're going to see that bone spur. And people are going to see it in X-ray and be like, that's it. That's what's causing it. But that's not necessarily the case. Yes, if you have plantar fasciopathy, you are more likely to have a calcaneal spur. That's how it goes. But there are plenty of people who have them who have no pain. And so it's not necessarily, once again, not the end all be all. And they don't really matter. We don't have to do anything to them to treat them. It's most likely just kind of a residual. The way I explain it to people is your body's clearly stressed, right? Lots of stress. This is the same thing on when you're the Achilles, you can have these bone spurs. Essentially what I view that as is your body's response to overuse is just kind of like laying down some more bone, just like, okay, I don't know what to do. I'm just going to do this to try to help. I don't know. I'll try and see if it works. And that's how I explain it to patients. Obviously it's much more complex than that. But when I see that, that's more of a cry for help and not the cause of the pathology. Could it get big enough where it's a huge issue? Yeah, I guess potentially that could be, but more than likely it's kind of just a, sequelae from the underlying pathology, what's going on. And then from an MRI perspective, you can get it, usually not necessary. You might see some thickening of the fascia, increased signal inside of the plantar fascia as well, but usually it's overkill, but it may help rule out other pathology. A lot of times when we think about plantar fasciitis or plantar fasciopathy, if it's an acute or chronic, it depends on what it is. If it's acute, you worry about maybe we have other things like going on in the calcaneus in the bone there. So it can look for other things which can be helpful, but from an imaging perspective, usually don't need it at all, but if we're going to do that, then maybe consider ultrasound. And from a diagnosis perspective, it's just clinical and physical exam, imaging not needed, like I mentioned. And when we are making the diagnosis, we want to think about the differential of what else could be going on here, right? So not every pain on the bottom of someone's foot is plantar fasciopathy. Common things being common, in primary care clinic, yeah, it's probably plantar fasciopathy. And our job is to rule out big, bad, scary stuff. Like I talk about all the time, but odds are if it, walks like a duck, quacks like a duck, it's a duck. And so same thing there. But there are a couple of things I want to think about here. First is a plantar fibroma, which is kind of just this little nodule that can get stuck in the plantar fascia, which isn't necessarily plantar fasciopathy. A lot of times it's hand in hand, but that may be different. Usually that one's a little more distal, so more in the midfoot. You could also have a calcaneal bone stress injury, right? Someone's increasing their running load. They're doing a lot of heel striking and they have plantar pain in their foot, but it turns out, hey, it's a stress fracture. That can happen. You might also have fat pad atrophy. We have fat pad right above the calcaneus because it kind of helps lessen the load in the calcaneus. You might have atrophy there or it's kind of decreased. You'd see that on ultrasound. And then also there's some nerves that go in there, specifically Baxter's nerve, which is the lateral plantar nerve. You can have that compressed and may mimic things, but a lot of times you'll have more nerve type symptoms, meaning numbness, tingling, kind of shooting pain into the foot, and not necessarily, the just with activity. A lot of times if it's nervy, they'll have it more consistently. It's not just with activity, whereas plantar fasciopathy usually it's like, I feel better at rest, but worse with activity. So that's, a very just general differential, but there are some things there that we have to think about. Not everything is plantar fasciopathy. So the big thing that we're going to rule out here is, a bone stress injury. And that's where an MRI might be handy if we're really, kind of cautious or worried about that, but not all the time we're going to get that. In terms of treatments, there's a whole lot of treatments, and the big thing is load management. I've talked about this with tendinopathy, same thing with plantar fasciopathy. But the one caveat is this is the one place where I'd say stretching in the data consistently shows it's helpful. I think most of the time I rag on stretching, which I'm not anti-stretching at all. Like I think stretching feels amazing. I just think if I had to pick between stretching or strengthening, I would choose strengthening every time because it just builds capacity a little bit better. But for sometimes that's what we need. And this one does seem to have some benefit for stretching. We're essentially stretching that big toe back like I showed in that physical exam, the windlass mechanism. We're just kind of stretching that toe back. That is an option too. And on top of that, we do have strengthening. And heavy, slow resistance seems to be, what everyone talks about. So heavy, slow resistance we've talked about in tendinopathy. That's where you're going nice and slow. Like specifically, you'll be on your toes here and going nice and slow up, maybe holding it top, nice and slow down. You'll have a towel underneath the toes. We'll talk more about specific protocols and treatments in the future, but that's what we tend to see is this strengthening. Eccentric is also an option as well, but heavy slow resistance is just slow, concentric, and eccentric. There are other options as well. NSAIDs only help with pain, not fixing the underlying problem because you are all geniuses now and know this isn't caused by inflammation. It's more degenerative, but NSAIDs are good at knocking down pain. So if we need to, we can do it. People have tried night splints before where essentially they wear these shoes and they keep your feet just like back. So you're kind of stretching out the plantar fascia. Data's pretty inconclusive on that. And it's just really practically a big pain in the butt to do that. And so I wouldn't want to do that. And so not something I'm recommending right away. Also, you can do extracorporeal shockwave therapy, which sounds super fancy, and it kind of is this machine that's really loud and just produces these shockwaves, and it can help reduce pain in the short and intermediate term. But once again, don't really think we're fixing the underlying problem. But sometimes with these extra modalities, like the big thing is things like shockwave, or as I'm going to get to here in injections, they may kind of help just bridge you through strengthening and getting you back in just kind of controlling our pain, right? That's the big thing is if pain's so bad where we can't do the things we want to do or build tolerance with our exercises, then sometimes we need to do things to help decrease the pain so then we can help do more. I've mentioned before many times that injections are a tool to kind of help us get it back and help us rehab. No different with shockwave. That's what I think about. And injection wise, there are multiple injectates that we can use. Steroids seem to be decent for short-term pain relief. Not advisable to get a lot of those injections. We're not fixing the problem first and foremost. We're just kind of masking it. And then if you do a lot of them, you worry about potential rupture of the plantar fascia or fat pad atrophy, which you want to have some fat there because it's a cushion between the ground and you. And so repeated steroids, I usually don't recommend. We can try dextrose prolotherapy, we talked about before in previous videos, that it may have some similar effects to shockwave in that it helps decrease the pain or maybe work even similar to exercise in terms of decreasing our pain. But once again, it is not fixing an underlying problem by any means. That is going to be through load capacity and management and exercise and whatnot, but may just kind of help down regulate pain receptors. And that's what we do. And then we also have PRP as well. PRP kind of mixed results. One study showed no difference between steroid and PRP. One study showed Prolo and PRP were similar. So from my pretty much general PRP stance is that it's really expensive. And if it's not going to show fantastic data, then I'm going to save $1,000 until it's my last thing I can try. So, and you can also do Botox injections. That's not a lot of data, even less data than like anything we have. So I wouldn't necessarily recommend it, but it's out there. And then the last final options are things like nerve ablations or radiofrequency ablation, where essentially are ablating or kind of zapping the calcaneal branches of the inferior calcaneal nerves to hopefully just decrease the pain sensitization, right? So essentially if we're saying, hey, if the nerve fibers aren't there, don't exist, then they can't feel pain. That's the general idea. And there is surgery where, you're essentially fasciotomy is you're doing such a cut in the plantar fascia, and it's the gold standard treatment. But just good news, 80% of people improve with non-operative therapy within 12 months. So most of the times you don't have to do that. And then I did want to mention real quick, there are some things out there in terms of people saying, hey, wearing natural footwear, minimalist footwear. That is definitely kind of a newer idea. And I was kind of looking through the literature. I didn't see a ton of literature on that. The literature I did see was kind of mechanistically based, meaning, hey, when you wear natural shoes, so when I'm talking natural, I mean zero drop shoes, meaning there's no difference between the toe and the heel. It's all on a flat line, as the traditional shoe has a heel elevation. People say when you do that and have a wide toe box, it lets your toes naturally splay out and it really strengthens your foot is kind of the idea. And it does show some muscle strengthening potentially in the feet, and which may be, beneficial. But I didn't see like really any data saying that, hey, this protocol of going zero drop and improving that is going to be beneficial. And in the meta-analysis I looked at, I didn't see a lot of foot strengthening being like a treatment. That doesn't mean it doesn't work. I've had people who've done this exact thing and had incredible results. And if I had to guess, it's probably more of a load tolerance thing. By doing this, we are giving ourselves the ability to kind of, we're cautious and we're saying, hey, we're trying this new thing. So we're just like slowly building it up, if I had to guess. But there might be something to that mechanistically. I just wanted to mention it because there's been some really popular podcasts who've mentioned this and like it's the gospel, and I just don't see that data on there yet. Is it safe to try? Probably, as long as we're not being crazy about transitioning to a zero drop shoe and anything like that. Reasonable, but I couldn't find a lot of data on it. So I just wanted to kind of be honest about things there, that it may be beneficial in the future and it may work. And I don't know that, but I don't see a whole lot of data indicating that's the definitive treatment of that. So we're kind of going to wrap up here though. So overall, plantar fasciopathy, this is from an insidious onset, pain at the base of the heel, right at the calcaneus, like I mentioned, right on the underside of the foot on the plantar aspect, usually worse first thing in the morning or worse after lots of use. You're going to have tenderness palpation at the medial calcaneal tubercle, or maybe pain with that windlass mechanism test. And for imaging wise, don't need it, but you can try ultrasound, which is helpful to see if it's thickened. And then we're going to treat it with loading and strengthening and a little bit of stretching potentially as well. And it's key to have expectation management, right? So about 40% of people who present will still have pain in 2 to 3 months. So I think it's advantageous to expect that this might be in for a little bit of time. When I tell people, usually for any sort of chronic thing, hey, this took a while to develop, so it's not going to get better in a day, right? It took a while, so it's going to take a while. So just setting expectations so people aren't worried that, man, it's 2, 3, 4 weeks out and I'm still not there. Like, okay, let's take a breath. many people have this for months and months. And I saw some data that was showing that a certain percentage of people had symptoms 10 years out. So for some people, this is just something they kind of deal with off and on. I wouldn't necessarily tell patients that. It's like, hey, you might deal with this forever. That's usually not ideal, and that's not the majority of people. But just understanding, hey, this may take a little bit of time, and just kind of considering, what's the time course here. So overall, though, that's going to be it for today. Thanks for stopping by. I really appreciate it. And sign up for the newsletter. If you want to stay updated anytime I release a podcast or something new, I'll shoot an email and let you know what's going on. I never send any spam because it's not a cool thing to do. I don't want to do that. But thanks for tuning in. I really do appreciate it. If you liked, commented, or shared with a friend, that would mean the most to me. But thanks for stopping in. Get off your phone, get outside, and have a great rest of your day.